So my objective is to just go over the definition of ARDS, the new definition, and our standard therapy for the ARDS-NET trials, and talk about refractory hypoxemia and how we utilize rescue therapy. And this is what you'll be doing. And some of you have seen this with us in the ICU, what we do for a patient with severe ARDS. But we're going to go over the evidence behind what we do that. This is all definition of ARDS, acute respiratory distress, bilateral infiltrate, no evidence of left atrial hypertension, so there's not a cardiac etiology for that, and PF ratio was less than 300. And then the new one, basically the same definition as far as the timing. It's an acute process within 1 week of insults. The infiltrate on the X-ray is bilateral infiltrate, and it also has, you have to exclude cardiac etiology from this bilateral infiltrates. And then they divide it into mild, moderate, and severe. So you think for mild, it's 200 to 300 PF ratio, and moderate 100 to 200, and severe less than 100. And we're going to start with the first question. So we have 45 years old patient with massive aspirations, developed ARDS, transferred to ICU, placed on 12 ml tidal volume, respiratory 12, feet 8, FIQ 40, plateau was 36, and then you elected to follow ARDS, so you dropped tidal volume to 6, and according to the trials, the ARDS trial, these changes for the first 2 to 3 days likely to lead to atrial withdrawal. Improved lung compliance and oxygenation, worsening lung compliance and oxygenation, improved lung compliance, no effect on oxygenation, or no effect on compliance and oxygenation.
B.
I'm sorry?
B.
Yeah. So when you're going to drop the tidal volume, of course, your compliance and oxygenation will get worse. That's the expected when you follow the ARDS protocol. And this is the trial in 2011 article. So you have the 12 ml conventional group, and you have the 6 ml, which is the low volume group, and mortality and morbidity as well as all is better in the low tidal volume, and that's what we'll be using. So the mortality dropped from 40 to 30. See here, and that's what we use. And it's basically reported in the Kaplan-Meier curve. So let's see the second question. Again, talking about standard therapy for ARDS. So first, we use a small tidal volume. This is another question that addresses another standard care. 56 years old male intubated on mechanical ventilation for ARDS. Blood pressure 130 or 80, pulse 86. Urine output is 0.8. According to ARDS-NET, the best fluid management and best method of monitoring is, and you have conservative fluid and monitoring device is equivalent. Conservative fluid monitoring, you need to monitor with pulmonary artery catheter. You need to have liberal fluid monitoring device equivalent, meaning that the central line versus, this is what they use, central line versus SWAN, the same. Or you need to use liberal fluid and use a monitoring device with SWAN. So which one, according to this, again, the second ARDS-NET called the FACT trial, which one is the standard of care?
One.
So conservative and monitoring device is equivalent. This is what the study is. It's called the FACT trial. It's large. Again, it's ARDS-NET trial, prospective randomized trial, about 1,000 patients. And they looked at the conservative management versus liberal management, and they looked at the central line versus the SWAN. And again, mortality didn't really change, but the ventilation days was different. The conservative was better, of course, the ventilation days, ICU days were the same. And you look at the organ failure score, organ failure, they call organ failure 3 days. There is really no difference concerned about the conservative group will have higher incidence of organ failure. It looks like for the cardiovascular, even renal, you can see here there's really no difference. So the organ failure no different, but patient gets off the vent and ICU sooner, so that's what we use, conservative management. Now, you be careful that you only use this in patient who has hemodynamically stable. So in the FACT trial, anyone in shock was excluded, anyone with oliguria was excluded, anyone with circulatory compromise was excluded. So the idea is that this hemodynamic takes precedence, and you have to make sure that if the patient is hypotensive with ARDS, you don't worry too much about conservative management. You need to give them fluid if needed. So that's the thing that you keep in mind. And from this FACT trial, we looked at the subset of patients that they received the SWAN, and the SWAN didn't really have any change on the survival organ function, or didn't have any impact on ventilations or ICU days. For that reason, there is no evidence to support routine use of pulmonary catheter, so we don't really use it anymore for this particular patient population. So just to summarize the earlier trials and what we do for the standard therapy for ARDS, you have the small tidal volume, you keep the plateau pressure less than 30, and you're using a modest PEEP, which we're going to discuss, and you use a conservative fluid management. This is basically what we have. Why it's important to look at the patient with ARDS and see their severity of ARDS, because it affects their prognosis and outcomes. So the patient improves in the first 24 hours, the mortality is really low, but if the patient didn't improve, their mortality can get up to 50-60%, especially with severe ARDS. Where this came from, there's a very nice study done by Wheeler that looked at the combination of PEEP and FiO2, which one that will differentiate between lung injury and severity of ARDS. And so they had 4 categories of patients. They have 100% FiO2, 10 of PEEP, 100% 5 of PEEP, 50% 5 of PEEP, and 50% 10 of PEEP. And they looked at the outcome for these patients, looked at the blood gas, did the regression analysis, and they figured out that the combination of 10 of PEEP and FiO2, 50%, best identifies the subcategories of these patients with ARDS. And they recommended that for you, as a treating physician, when you get a patient and you want to try to figure out exactly these patients are lung injury only versus moderate to severe ARDS, you need to put them at least on a 10 of PEEP, 50% of FiO2, and get a PF ratio, and then you can figure out exactly where are they falling, and then you can determine if you are going to be using any of the rescue therapy. And just to remind you, after you do all this and you assess the patient in the first day and you do your FDF ratio and so on, you're going to be familiar with the term of refractory hypoxemia, severe ARDS. These are a group of patients that have a PF ratio less than 100, or you're unable to maintain a low plateau pressure despite using a very low tidal volume, or the patient have high oxygenation index. And the formula to calculate oxygenation index is FiO2 times the mean airway pressure times 100 divided by PO2. Or if the patient develops paratrauma as a sign of lung injury, that's also one of the diagnostic criteria for refractory hypoxemia. Another term that you need to be familiar with, patient with high ventilator requirements. These are people who are more than 70, FiO2 15 of PEEP, and also have high plateau pressure with low tidal volume. These are also considered to be severe ARDS, high ventilator requirements, refractory hypoxemia. These are the ones that you really need to look after. Try to figure out this group of patients in the first 24-48 hours, so you can determine which rescue therapy you are going to use. So don't wait too much, first day or two, try to figure out exactly where the patient is hitting. It's improving, the mortality is good, and they're getting worse or the same. The mortality is in the 50-60%. So before I address some of these rescue therapy, these are some of the guidelines. You use it for patients with severe ARDS, refractory hypoxemia. There are ventilatory measures, there are non-ventilatory measures. We're going to touch both of them. The choice is really should be based on your expertise and the evidence in the literature, which I'm going to discuss, and also the availability of equipment. Some of the rescue therapy, like ECMO, is not going to be available everywhere. And then if you're going to be trying rescue therapy, make sure you have an exit strategy. So if it works, you are going to continue, and if it doesn't work, then you're going to have to stop. You don't want to continue ECMO, for example, for a month or 6 weeks just because you have the ability to do ECMO and the patient is not getting better. So you're going to have a way of stopping. So these are the list of the ventilatory, non-ventilatory strategies that has some evidence in the literature, which I'm going to address today. We have the PEEP, the recruitment, transpulmonary pressure targeting ventilation, like using the balloon, oxygen balloon, prone position, neuromuscular blocker, ECMO, nitrate, and high frequency. So first the PEEP, and we're going to start with a question. So you have 58 years old with ARDS. On mechanical ventilation, total volume is 6 ml as recommended. FiO2 70, PEEP 5. Blood gas is acceptable. His petrol pressure is 25. In an effort to reduce the FiO2, we went up on the PEEP to 12, and this resulted in reduction of the FiO2. Based on the large randomized trial, this change will also reduce the plateau pressure, improve mortality, reduce plateau pressure, not affecting mortality, increase plateau pressure, improve mortality, increase plateau pressure, not affecting. So when you increase the PEEP, what happens? I'm sorry? Increase plateau and no effect on mortality. So that's basically what it is. Number 4. And this is based on these large randomized trials. So this is ARDS-NET trial. It's called the alveoli trial. So it's another arm of the ARDS-NET. So we talked about the first one and the fact, and this is the third one. And then you have 2 trials that were also published after this one. So this is 2004, this is 2008. You have the EXPRESS trial and LOVE trial. All of them looked at low versus high tidal volume. And if you look at the protocol, this is a very busy slide, but I'll walk you through it. You have a control group that has a low tidal volume and low PEEP range of 8 to about 10 to 11. And you have the high PEEP, which is 11 to about 15 or 16. And the 3 groups are the same, or 3 trials are the same. And they looked at the outcome. All the 3 trials have shown improvement in oxygenation, or the PF ratio is improving with the higher PEEP. So all of them had the same results, okay? None of them had any survival advantage. That's why we say there's no mortality benefit, but there is improvement in oxygenation. And then if you look at the 2 Canadian trials, the EXPRESS and LOVE, the refractory hypoxemia and death from refractory hypoxemia were less than the high PEEP. And that's what we recommend for these patients, is to use the high PEEP rather than the low PEEP. You're going to need to know if your patient is going to benefit from the PEEP or high PEEP, so we recommend something called recruitment maneuver, which we'll discuss a little bit. And then, so you can start with a low PEEP and you keep going up on the PEEP, or you can start at a high PEEP and you go down until you have deoxygenation and then you stop. So you can do an incremental or decremental PEEP increase. We usually start with this one, the incremental will go up. But the recruitment is different. I'm going to explain it to you. You can do a recruitment maneuver with a PEEP, or you can do a recruitment maneuver with a PEEP and pressure support, the pressure control. The idea is that you go on up in the PEEP to about 30 or 40 for about 20 to 40 seconds. and then you drop them down to the high PEEP range, not to normal. And if you're using the combination of PEEP and pressure control, you do a pressure control maybe 15 or 20, and you do a 25 or 20 of PEEP for another, also again, 30, 40 seconds, and then you drop them down. So that's basically what you do to recruit. And if you see an improvement of oxygenations, you drop them to the high PEEP and you leave them, so you can do that. Most patients with severe ARDS, they're going to be requiring PEEP in the range of 8 to 15. I would recommend that you choose the 11 to 15 or 16 range, which is the higher PEEP, which will help the patient with severe ARDS. So the recruitment, let's talk about this. There's a question here. Morbidly obese, BMI of 53, on a vent, and has severe ARDS. Vent setting tidal volume was 530, that's 8 ml for ideal body weight, and 100% FI2 people 12, and then if it was 52, CO2 was 64, pH 718. His plateau pressure measured at 38, and which adjustment to the vent should you do to address the hypoxemia and maintain the lung protections? So you have an option of increasing PEEP, accept higher plateau, increasing PEEP, reduce tidal volume, increase tidal volume, reduce PEEP, and then reduce tidal volume and PEEP. So the answer is 1. And the reason for this is that this patient is obese, and this plateau pressure is probably not reflective of his transpulmonary pressure. This is just because of his morbid obesity. His plateau pressure is high, and that's why we are going to be talking about not only the line recruitment, but we'll talk about the, sorry.
Why wouldn't you just use 6 cc's?
I'm sorry?
Why wouldn't you use 6 cc's?
Again, so the tidal volume I will use for this patient is going to be based on the transpulmonary pressure. So you keep this in the respiratory transpulmonary pressure below 25. So yes, you want to use 6 ml per kilogram ideal body weight, but the idea of using 6 ml is to maintain this plateau pressure. Mm-hmm. And since in this patient this plateau pressure is not accurate, I would use the transpulmonary pressure to guide your tidal volume and guide your PEEP.
But you don't have that. Not everywhere has those.
No, that's true. I mean, but it's available everywhere now. This transpulmonary pressure, it's available everywhere. It should be.
Dr. Saad, for that patient too, in that example, his pH is already like 7.1.
7.1, yes. Right. I sometimes go above the 6 if the transpulmonary pressure is low. I mean, this is going to be my
Yes, but in that question, you don't know what the pulmonary pressure is. You should know that the tidal is high, and they're not using.
Yeah, I mean, yes. I think for him, because he's also hypoxic with a VO2 of 50 something, and he's on PEEP of 12, and the question is, if you want to be improving his oxygenation, what are you going to do? It's already 100% FI2. So are you going to go up on the PEEP? Because you know you're going to go up on the PEEP, the plateau pressure is going to go high.
Yeah.
So, and the question is addressing the thing that this high plateau pressure is probably not reflective of his pressure. So again, the lung recruitment, I talked about it. I said you can use your PEEP 30 to 50 centimeter water in 20 seconds, 40 seconds. You can use combination of PEEP and pressure control. And the recruitment maneuver was looked at several trials, all of them showing improved oxygenation. This is just an example of some of these evidence. You can see here prior to recruitment and after recruitment, your PF ratio improves. So there is an improvement in oxygenation, but you have to be aware of the complications. You can get hypotension. This is 12%. Some of the studies reported 12% incidence of hypotension, 8% you can get desaturations, and you can have 1% arrhythmias and 1% pneumothorax infarction. So that's some of the potential complications with lung recruitment. You don't need to use it routinely. You just use it as a rescue. to get the oxygenation up, and then you put on high beat. You don't want to use it in patient with hemodynamic compromise because that's going to get worse, or your patient with severe maybe emphysema and you worry about paratrauma, you don't want to use that as well. And then the transpulmonary, this is what the question was referring to. So this interest started about more than 10 years ago. Talmor is in Beth Israel in Austin, and he started interest in this, and I published in 2006 that the patient was different level of ARDS, varied greatly in the transpulmonary pressure measurements, and then he started this randomized trial in 2008. It's called EP-VENT trial, which had to stop after 60 patients. So they were supposed to recruit 150 patients, and then they stopped after 61 patients because of marked improvement of oxygenations in the patient that receiving this gel pressure versus the conventional therapy. So they had to stop, and the mean increase in the PF ratio in this esophageal pressure group was 88 millimeter mercury. So they had to stop this and reported it, and now they are actually doing EP-VENT 2 trial, which started in 2012, already enrolled 200 patients, moderate to severe ARDS by definition, less than 150 PF ratio. This protocol, I'm giving you the protocol, less than 150, they enrolled 200 patients, and they're supposed to complete, they need another 20, so they're supposed to be completing. If you look at the clinicaltrial.gov, they said that it's supposed to complete in September of this year. So they want to, hopefully they're not going to stop it. They haven't stopped the trial this time, so they are going to report the benefit of using esophageal balloon-driven ventilation versus conventional therapy. So looking at the EP-VENT 1 trial, you can see the trend. There is a trend, not statistically, but there is a trend. Remember, we stopped at 61 patients. There is a trend of mortality benefit. ICU length of stay was better, and ventilation days were better. But of course, the number of patients was limited. That's why it didn't really have statistical significance. But at least there is a trend there. So as I said, the EP-VENT trial is underway, and they're going to complete it in September this year. Cloning has a lot of interest for years, starting from early in the 70s. And most of these trials that were done on the prone positioning, all of them showed improved oxygenation. There was different variation in the protocol. Some of them used cloning for 6 hours, 8 hours, 10 hours, different things. And this is one of the earlier trials by Gadinoni, and that's looked at 304 patients, did cloning for 6 hours, for 10 days. But they used high tidal volume at that time. The low tidal volume was not there. And advantage of the survival, but there's some improvement in oxygenation. So that's basically some of these reports from the prone position. And another trial, 2004 to 2008, they're all the same improved oxygenation results, no mortality. So it's the same concept. And then another one in 2009, which is this one, published in JAMA. They did it for a longer period of time, 20 hours. Again, showed oxygenation improvement, but no mortality. So these are the report of this 2009 trial. And you can see here, there is really no, there is a difference in the need for sedation between, of course, the cloning and non-cloning. Also, vomiting was more, and arrhythmia. So there's some complications that was reported, which is expected in the patient who received prone position. Now, the final thing that came out 2013 about the prone position, French group. So this is the most recent one, and we have 400 some patients, moderate to severe ARDS. They did it early, polling within 36 hours of incubation, and they continued the polling for 16 hours. So remember when they started, they had like 6 hours, 8 hours, 10 hours, so they were experimenting with the duration. And again, this trial was started within 3 days. Now this is 36 hours, so shorter. You start early and you do it longer. That's the key here. You start early, do it for an extended period of time, and in this particular protocol has resulted into mortality benefit and also ventilation days, and was better. Now the thing about this that was striking is that there is no difference between both groups when it comes to complications. Now, you have to understand that the trial was done in centers that had experience with prone positioning for over 5 years. And this is a key for minimizing complications. So all these centers that was participated into this trial have been doing poning, and we have experience with it for at least 5 years. So you cannot say that if I do poning in another institution, then you're not going to get complications. You're probably going to get complications, but you're probably going to have the same results when it comes to mortality and oxygenation. So if you know how to do it, and there is a video on this particular New England Journal issue, there is a video of how you do it. And Nurses Education, actually Jewish, downloaded this video, and they were doing education for the nurses in anticipation of hopefully trying to do this at some point. But there's a video that educates the nurses on how to do it. And this is basically a summary of the results. Again, mortality was good, and the 28 days free ventilation days was also better. And you can see here the code. So that's the most recent, and if you have the ability to do that, you can use it as one of your methods of rescue therapy. And then neuromuscular blocker. And the idea about neuromuscular blocker is that you're trying to decrease the vocal breathing, so you decrease the oxygen consumption. That's the one positive thing from the paralysis, and also improve the ventilation synchrony. That's will be another advantage. There's an earlier trial done 14 years ago, looked at the neuromuscular blocker, but didn't show any mortality. There's, again, improved oxygenation, but no mortality. And then there was a concern of an earlier trial about myopathy and increased paralysis and polyneuropathy, so I've been concerned about it. And you can see from this earlier trial, oxygenation improvement with the paralytics is there. Until recently, again, this is 2010, French group also, studied the neuromuscular blocker for 48 hours. So they will paralyze the patient for 48 hours. Again, these are all moderate to severe. Versus control group. Both groups had the same protective lung strategies, smaller volume. There was no difference in ICU weakness. They measured the muscle weakness, and both groups, there was no difference. Again, you only use it for 2 days. But they showed improvement in mortality and improvement in ventilation 3 days. So that's another protocol that you can implement, is to paralyze the patient for 2 days and take over the ventilation for them, and that should help in the outcome. And that. You see it here, the mortality and paratrauma is the same, and ventilation days less. ECMO. Again, earlier trial in the 70s was really had a bad survival. Survival was only 10%. So this is very old trials from 79. Looked at these patients with the ARDS, and recent, this is again one of the earlier trials, not earlier, but this is the Caesar trial actually, from England. They looked at ECMO versus conventional therapy. We're going to talk about this a little bit. 180 patients. We will have a referral center that the patient will come to for ECMO. The problem with this trial is that the control group did not get the same lung protective strategy, so there was only 70% compliance with the lung protective strategy in the control group versus 93% in the ECMO group. So there's variations between both groups when it comes to implementing the standard of care, and so that's not good. However, this trial showed survival advantage of ECMO, 63 versus 47. The criticism, of course, is the disparity between the both group. They didn't really get the same lung protective strategy, and that's why people will criticize this article, saying that the benefit or the mortality benefit of the ECMO is most likely related to using lung protective strategy, right? For that reason, now they are doing this trial, the Uruguay trial. It's actually completed just 4 months ago, and they're analyzing the data. So this trial is exactly similar to the Caesar trial. However, both groups received exactly same protocol when it comes to lung protective strategy. Okay? So we're going to find out if this ECMO from this trial is going to be positive or not. I think if it comes back positive, people are going to be maintaining interest in it, but if it comes back negative, like what happened with the high frequency oscillation, I think it's going to kill it. But I want to go over some of the reports, from the positive reports from ECMO. I want to remind you about the H1N1 in 2009 and 10. A lot of publication came out from a New Zealand group, from German group, looking at their own patient population that had H1N1 acute lung injury and the outcome from the ECMO. All of them have reported fantastic results. You have 71 survival, and one reports 55, and another reports 46, and third. And if you look at the patient population, you find that they're all young, not sick. They're all young, no comorbidity, and they all have H1N1 acute lung injuries. So when they put them on the ECMO, they all survived or had a very good survival. Although you cannot really use the same number here for 70 years old patient with heart failure, maybe COPD, and so on. But these are the reports from a healthy patient during this H1N1. So we're going to need to wait and see what the result of this, as I said, just recently completed. But again, ECMO is not available everywhere. It is expensive. Has complications. Patient bleeding. You have to be paralyzed. There's just so many things that happen with them, infection, of course, and other things. So, if you're going to be using it, you're going to need to know when to use it, what are the ideal patients, and let's see if we can get some results from this trial. Nitric, because it has been used as a rescue therapy, and the evidence is not that strong, so these are multiple trials from the 80s, 90s. They all looked at nitric versus placebo, of course, and all of them showed oxygenation improvement, but no survival advantage. So you can see one of them here, no mortality benefit. And you can see even the report of oxygenation improvement is limited to the first 2 days. So when you start using the nitric, you can see that in the first 48 hours, you can see the split between both groups. The PF ratio is much better for the first 2 days, and then by day 3, 4, 5, they're overlapping. So you can see that you lose this advantage after the first 2 days. So it's expensive therapy, no mortality, short-lived improvement in oxygenation. That's what you get with the nitric.
What do you think of that dose they used?
They look
Apart from-
5 and 10 actually even, but not the 20. Yeah, but that doesn't, I think there is also reports of using 20, there's no difference between 20 and 10. Using 20 parts is not different, 10 is not different. I don't think it's really matters how much you're going to be using them. Cardiology, cardiothoracic, sometimes using 40.
Yeah, they use 40 instead.
Yeah, I don't see any advantage of that. There is no evidence that this 40, and there is nothing in the literature that says 40 is better. But I know that 5 and 10 and 20, there's really no difference. So, high frequency, this is the, used to be popular in the past, and the idea is that you want to deliver small volume, rapid rate, to maximize mean airway pressure, to improve oxygenation, and at the same time you decrease lung injury. Several trials have done that showed improved oxygenation, no mortality, until we had these large trials, and Oscillate. Both of them were published around the same time, about 5 years ago, 4 years ago. Both of them showed, actually, one of them showed, Oscar showed no improvement in oxygenation or survival, and the Oscillate shows worsening mortality. So Oscillate had to be stopped because of the mortality that was high in the treatment group. So this basically, these two trials killed the high frequencies, or nobody used it. I think there's still use of high frequency in kids, because I think the evidence in kids is still there. So I think they're still using it, but I think for adults, this very much end the use of high frequency. Now, one of the things that you need to know about why the Oscillate had higher mortality in the treatment group, we used high PEEP in the control group in the Oscillate versus the Oscar. So the Oscar, the treatment group, the control group had a PEEP of 10, and the Oscillate, they used a PEEP of 15. So you can see the difference between 10 and 13. So both protocols are identical, except you used a little bit of higher PEEP in the Oscillate in the control group, and people who reviewed this article, they said that the difference in the outcome is related to the higher PEEP. You use a higher PEEP, so you had a better outcome in the control, and for that reason, the mortality was higher in the treatment group. That's basically the only difference between Oscar and Oscillate. The PEEP was a little bit higher. Other than that, everything was identical, the patient population was identical, and that's basically killed the high frequency, and nobody is thinking about it anymore. So in conclusion, the mortality of the ARDS improved with the, of course, low tidal volume, the conservative fluid management, and so on. These are all improved the mortality from ARDS. The refractory hypoxemia identification is very important. You have to do this early in the first 24 to 48 hours. The strongest evidence for mortality benefit out of this rescue therapy that I showed you is for high PEEP and early neuromuscular blockade for 48 hours, early prolonged cloning, so you use 16 hours, you do it in the first 36 hours. These are the highest evidence, and these are the ones that showed mortality benefit. ECMO, we have to wait on the new trial because the Caesar trial has a disparity between both groups as far as the conventional therapy. GL manometry, there's no survival advantage, but there is an oxygenation improvement, and we're going to need to see the second phase of that to see if there's any mortality benefit. But I think you can use it to guide you for improved oxygenation. No evidence for nitric and no evidence for high frequency oscillation. That's been I think, put to rest. I don't really use it anymore. So these are the 3 maneuvers that you can do and has highest evidence, and then you can consider oxygen manometry. Consider the ECMO, in my opinion, for young patients with no comorbidity. I think they will benefit until we get the results from this trial. And that's what I have. Questions?